Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Roche.
This program is presented by Medscape Education Global.
Hello, I am Patricia Udaondo. I am a retina specialist based in Valencia, Spain, and I would like to welcome you all to this program entitled Managing Diabetic Macular Edema in Clinical Practice. And I couldn't imagine best colleagues and friends than the ones that are with me today: Andreas Polsreis, based in Vienna, Austria, and Ian Pierce from Liverpool, UK. Hello to both of you, and thank you for sharing with me this program. So I just would like to give as an introduction the situation now with DME, mainly with the anti-VEGF therapy. So nearly 20 years ago, we had the first treatment based on the blockage of VEGF, and then we have the first generation of anti-VEGF with a nice response, but then it seems that we had new things to face and to improve with the treatment. And very recently, we had the new generation of anti-VEGF therapy with a longer duration. So we welcome to faricimab and aflibercept 8 milligrams. And we would like to discuss what are the data that we have nowadays and your experience with the introduction of this new anti-VEGF therapy in the management of DME. So my first question is coming to Andreas. What are the main drivers for you to use a new generation of anti-VEGF over the previously or standard anti-VEGF therapies in DME patients, Andreas?
So in our daily routine, we face quite significant changes with our diabetic patients. And for that, I think we should try our best to get the best tools out of our pockets. And with two new drugs that came on the market in the past years, I think that's something to be excited about. And both drugs, faricimab and aflibercept 8 milligram, are exciting. They are exciting in their own way, with faricimab having a dual action. Faricimab inhibits both VEGF-A and angiopoietin-2. And aflibercept 8 milligram is basically 4 times the dose of aflibercept 2 milligram, which was the previous version of it. And what we saw from the phase 3 trials, so Yosemite and Rhine for faricimab, and the Photon trial for aflibercept 8 milligram, was that we saw quite a fast and potent visual acuity increase, but more so a strong morphological response. And what we could also observe, and I think that's what we are all most excited about, was the duration. And duration, I think that's something not only for us as clinicians, but also for patients, what matters most. We don't want to see the patients that often, and also we don't want to inject the patients that often. And this was quite exciting to see with these new drugs, because when you look at the phase 3 trial data, we see that at the end of the second year, 80 to 90% of patients were at least in the Q12-week interval. And that's actually what we would like to see also in the real world. So I think it's exciting times, and it's exciting for retinal specialists to have new tools in our hands.
I think what you said is very important, because we are keeping the efficacy in terms of function, which is important, but we are extended or in an important manner the intervals, which is also important, as you commented, in terms of burden of treatment. So in your personal experience, are those intervals in real life compared to the trials be followed with these new anti-VEGF therapies?
Yeah, so when I take our own clinic here in Vienna, and we are a big diabetic unit in Austria, so we basically get at the end of the first year an interval in at least treatment naive eyes of almost 15 weeks, and I think that's something that is quite satisfying to us and to the patients. And in previously treated patients, we're a bit below that, around 13 to 14 weeks. But I think these are similar data that we've also seen in large retrospective real world studies. For instance, from the UK, the far wide DME data, which includes more than 1,400 patients. And we also see similar results here. So that's quite reassuring that what we see in a single center is also replicated in large trials. So we see similar extension periods with about 14 to 15 weeks on average after the first, but also in the second year of treatment. And also similar results are reported for instance, far retina DME. So these are data, retrospective data from the IRIS registry of the American Academy of Ophthalmology. And we also see extension intervals of 16 to 12 weeks, longer in treatment naive eyes, also what we see in our clinic, and a little bit shorter in previously treated eyes. So these are data for faricimab. We also have data for aflibercept 8 milligram. Here we have also data from the US, from the Vestrom Retina database. But also here with aflibercept 8 milligram, we see that after the loading dose, we have on average intervals of about 11 weeks in both treatment naive, but also previously treated eyes. So again, different countries, different study populations, but similar directions in terms of duration. And again, duration is something that us as clinicians are aiming for when we get a new drug in our hand.
So following with your comment, based on the results coming from different countries, I'd like to exactly ask Ian about that. Why do you think we are seeing differences between the intervals in clinical trials according to these observational studies coming from the different countries around the world? What are your thoughts about that?
Well, I agree with there are differences, but I think the consistencies within the studies actually far outweigh the differences. And what I mean by that, if you look at the pivotal trials, the numbers of patients, a percentage of patients getting out to 12 weeks or 16-week intervals, they were very high, 80% plus. Now, when we've done the real world data analysis, both in the form of far wide in the UK and far retina in the US, there is a slight reduction, but it's a slight reduction. If you take the UK data as an example of that, the average interval at the end of 12 months in treatment naive, as Andreas has shown, is nearly 14 weeks. Well, that's actually very, very reassuring. Now, it's not the same proportion of people in the Rhine and Yosemite pivotal trials, but in those trials, there were specific criteria that would allow extension or reduction in the interval. And you had to meet certain thresholds in terms of change in vision or change in macular edema, central foveal thickness. Well, in the real world, we all adapt slightly different protocols. We all adapt slightly different thresholds personally of what we will accept. So it might be that in the real world, if we see any edema, we say, no, I'm going to retreat. Whereas in the pivotal trials, those patients may have been allowed to be extended. So I think when we moved from pivotal trials to the real world, we expected to see a reduction. I think what I'm surprised about personally is how little of a reduction we saw. And that's in the real world with patients with uncontrolled blood pressure, HbA1cs that are much higher than would be allowed in the studies. They're in patients that are all comers. They're not just ones who are going to turn up at every visit. So I think what I was reassured by when we saw the far wide and the far retina data is how aligned it was with the pivotal data. Now, when we turn to 8 milligram, again, the study was designed that you had to meet certain threshold to have a reduction in your interval. And this is not unusual for pivotal trials. And we're starting to see some early data of 8 milligram of aflibercept showing good results. The problem is that we've only got early data. For 8 milligram of aflibercept, we've only got maybe up to 6 months. We're looking with interest at how those intervals will be maintained as we go onto longer intervals as that data accumulates.
No, I agree that the final message is exactly that we are extending the intervals. And probably the two main reasons why the results are different is the profile of patients, that we are treating in real life all kind of patients, and also that we don't usually tolerate the fluid. And maybe we are not familiar with doing that as we do in the clinical trials. And I would like to know your opinion about what other additional benefits you find from this new generation of anti-VEGF treatments, Ian.
Well, I think we've seen it from post-hoc analysis from the pivotal data, but there's certainly an increased drying in the first few months compared to our previous gold standard, which would have been a first generation 2 milligram of aflibercept. That was our gold standard for 10 years almost for treating diabetic macular edema. I think now with these second generation drugs, we're seeing improved drying at an earlier period. And what that manifests as is increased durability. What does that actually mean? Well, what it actually means is patients are needing less and less injections over 1 year, over 2 years, and as we've seen in the extension trials, over 3 and 4 years. And I think that has a massive impact. Not only is the patient not having to return and have the injections, but it's helping the service as a whole. We're a state service in the UK. Capacity is always an issue, and the durability and those reduced numbers of injections each year are just manifesting itself as an improvement to our service, and we can provide timely treatment and when we require it.
Andreas, do you have any comment on this?
I just want to add here the kind of easy application of these drugs, which I think is an important factor for me, but also for a lot of other clinicians worldwide. And I think that's also the reason why we see these kind of consistent data, because whenever you have a new drug, you don't know how it will turn out, after 1 year of treatment and after 2 years of treatment, also during your treatment episodes. But I would say the vast majority, I wouldn't say all, but almost all patients, when I decide to extend the patients and they come back, there is not a disaster that's waiting for me. And I think that's the important part of these next generation drugs, that whenever you do extension, the patients do in most of the cases well. And I think that's the good part of that. And that so many clinicians worldwide get similar results. And I mean, you find this all over, the literature. You have small centers, you have large centers, you have pooled data, you have registry data. I mean, we need to be cautious when interpreting all this real world data, right? Because real world is not real world. A small center might have like higher quality data than larger retrospective data where some centers are pooled, but they all point into the same direction. And I think the most important part for me is when using these next generation drugs is that obviously I get longer duration, but I do not compromise vision. And I think that's the most important thing. Although vision might hit a ceiling, it all obviously depends on at which level we start. For instance, in Austria, most of our patients start pretty well. So we don't start with 20/40 or something like that, which was like the inclusion criteria of the studies. But we start on a higher level, means that we don't have so much letters to gain, but still we get longer durations and we do not compromise vision in the end. I think that's at least the most important factor for me.
Yeah, I was saying exactly the same. I think to me, the most important is that we have a better disease control. That's why we can extend, and the duration is shown in the treatment of patients, and we are getting more confident. So I think that's, to me, very important as a clinician. We are all familiar with these thousands of talks about biomarkers and if they are useful or not in deciding the treatment or in predicting the response. So I would like to know from your point of view, if you really follow these biomarkers based on imaging to decide the treatment that you start with, or during the follow-up, do you consider these changes into the biomarkers to change your treatment or not. For example, we know that since last year, we have many more data coming from faricimab because it came first to the market. But we have started to see, for example, sub-analysis of the phase 3 trial showing that we have a greater reduction in the number of heart exudates when we are comparing faricimab to aflibercept 2 milligrams. Also, we seem to have a benefit on the macular leakage or also into the presence of hyperreflective foci. So are you really using these biomarkers in the daily practice or not really? For example, Ian, you start and then Andreas.
Yeah, so I agree with you. I mean, there's a lot of post-hoc analysis coming out. All these biomarkers are very interesting, and I think they point to some extra effect of potential ANG2 blockade. Now, as you pointed out, we don't have that same data at the moment for 8 milligram because the studies were later, and I expect that we will see some of this biomarkers. Your question is do I use them in day-to-day practice? And the answer is not in terms of deciding whether I start on, drug A or drug B. I think what they'd help me is to give me confidence of whether I feel this patient is likely to respond well. It's almost a prognostic factor. And I think that's where its role is at the moment, deciding exactly would I use one drug over another. I'm not sure at the moment. Macular leakage, I think, has been one of the biomarkers that stood out for me. And the reason why it stands out for me is that 2 milligram aflibercept versus faricimab in the Rhinary Cemetery trial, there was a significant reduction in the amount of macular leakage at the end of the match phase of loading. So that's all the drugs had. They'd had the same regime. At the end of 16 weeks, you look at the macular leakage and it's significantly reduced in the faricimab arm. And I think that's probably why we're getting that increased durability. If you've got increased stability of the macular, the capillaries around the macula, then likely you're going to have reduced edema and you're going to have less likely to have a recurrence, and therefore your durability will increase. Now, the reason why it stands out to me is because that same data has been showed in the Photon trial in 8 milligram versus 2 milligram. So in the Photon trial, the 2 milligram arm and the 8 milligram arm, yes, they have both had a reduction in leakage, but it was the same whether you were on 8 milligram or 2 milligram. So you didn't get any extra bang for your buck. You didn't get any extra effect on macular leakage. Whereas in the Yosemite Rhine, we saw the opposite. You did actually see an effect. And to me, that's probably the best biomarker that I've seen that's suggested to me, yeah, ANG2 blockade is having an additional effect. That's what the science told us. That's what this early studies suggested. And I think that's what we're seeing in real world. So I think that's where the biomarkers are at the moment. We're looking at them. We're trying to understand them, maybe have prognostic factors. Does it change my clinical practice at the beginning at this stage? I'm not so sure. I don't know what Andreas's view on that in clinical practice is.
Well, Ian, I totally echo you in terms of leakage. I think these data are fascinating. However, and that's also, I'm totally agree with you. Do I use it at the moment? No. Why? Because I start on the best drugs available, right? So this is the important thing. However, if you are in a country, in a region, in a hospital where this is not the case, you might want to look at, for instance, a macular leakage. That's something that we regularly do when patient comes in. We do a FA to look at ischemia, but also at the leakage. So that's something that you might want to consider using a faricimab, for instance. Or if, and I think that's also important because this has an immediate effect on visual acuity. These are hard exudates in the foveal center. And also here, I mean, data are coming out also for faricimab, most likely also for aflibercept 8 milligram, but at least what's been presented with faricimab is the kind of reduction in hard exudate volume. And if this is the case also in the fovea in certain patients, I think this would be an indication to use like faricimab over like a previous generation drug. So I think in the future, for some countries, for some regions, this might be an important decision, these biomarkers. But again, as you said, for me personally, at the moment, I'm looking at these biomarkers and they kind of reconfirm that the treatment I chose for this particular patient is doing the best possible action. And that's why I like to look at these biomarkers. But I think in the future, and also taking into consideration the potential of AI when combining different biomarkers, even combining different imaging modalities. This will also help us. So I think the biomarkers will be something that matters a lot in the near future, also in terms of retreatment, also in terms of when we want to see the patient again, and so on. So I think it is an important factor. They are very important already at the moment, but they will become even more important in the near future, I guess.
Yeah, I agree. So we've been talking about the efficacy, the intervals, but what about safety, Andreas? Any particular concern about the new anti-VEGF and safety?
Well, to answer this question simply is no, because we saw the data already from the phase 3 trials, where there was no significant increase in any kind of adverse events. And also after millions of doses being distributed worldwide, there is no new safety signal popping up. So I'm not concerned. And yeah, we have no major safety signals coming up in our clinic. So that's also parallels of what has been reported in the phase 3 trials, but also what has been reported in the retrospective large real world data.
I think that's very important too, to be also repeating the safety profile of the first generation. And Ian, what about the extension, the data on the extension study that are ongoing now? Because I think it's important also to understand if this effect is maintained or not.
Yeah, definitely. I mean, I think the extension trials are important. In terms of faricimab, we've got the RONEX, which is a 2-year extension on top of a 2-year trial. So we've got 4 years of experience. And in terms of the Photon study, we've got a 3rd year of extension as well. So I think we've got good reassurance of what happens to patients in the long term, both in terms of efficacy, but also in terms of safety. So I think that adds to that safety question you just asked, that you get increased confidence, not only in the short term, but in the long term of the safety output, the output from that. One of the things, if you look at just RONEX alone, so we've got 4 years data here, where you've got some patients who started on 2 milligram 8 weekly for 2 years, and then was switched over to a treat and extend faricimab arm. Now, if you look at those switch patients compared to the treatment naive patients who was treated right from day one with faricimab, you could say, well, at the end of the 4 years, you end up at the same point. 95% of patients are dry. They've got a good improvement of vision. They're on extended intervals by the end of the 4 years. And for us, that could be interpreted by the payers saying, well, okay, well, let's start with a biosimilar 2 milligram first. And if you're not doing well after a while, switch over. Because at the end of 4 years, you do fine. But what you've got to remember is that journey of that patient. So that 2 years and then switch for a patient means more injections, more visits. All right, final outcome may be the same, but in between, they'll have dips in their vision as edema is recurring and they're needing switching over. So my fear is that we look at the extension data and go, oh yeah, you end up with the same result, but you've got to remember the journey. More injections for patients. I think the numbers, you're something like over 4 years, maybe 5 to 6 injections more, certainly for faricimab, and the same with the Photon, but over a shorter period of 3 years. But patients are needing more injections. And I think you've alluded to it already, Patricia, this impacts not only the patient, but it impacts on the service that we can provide. We can't get patients in if our clinics are full of giving injections. So if we get increased durability, not only is patient benefit, the services benefit, and it's a positive circle. It comes back around. If we can get patients in, we can treat them better, timely. Patients do better overall. So I think the extension studies give us that confidence. We just need to make sure that, if we're faced with, well, start with a biosimilar because you'll end up the same place. You must remember the journey, not just the 4-year point. I think that's key, both for us as physicians, but also particularly for our patients.
Yeah, exactly. I think what you commented, I think it's very important. So one question, because it's been a global trends survey in the ASRS about which treatment you start in DME, with the old or first generation or with the new generation. And it seems that 50% of clinicians still start with aflibercept 2 milligrams, and about 30% start with one of the two new treatments. Is that what you are doing? It does reflect what you are doing, or you are more using new generation compared to the first generation?
So in our clinic, we switched completely to the new generation drugs. So we used to use aflibercept 2 milligram, as I think is also the case in Ian's clinic, but now we switched to the new drugs completely for the reasons we mentioned before: longer durability, less visits for the patients, and I think what's also important to add here is the satisfaction of the patients, right? Because we always have the risk, particularly with diabetics, particularly with younger patients, that we lose them. And I think losing diabetics at a certain stage is very bad. It's very bad for the patient. It's also very bad for us, because then we start from zero again. And when you have a potent drug in your hand and the patient immediately realizes that there is success, that patients see better, that when you show them the OCTs, that there is a good response. And you can also say to the patient that you need to come in 8 weeks, you come in 12 weeks, you come in 16 weeks, you come in 20 weeks. That's something that motivates those patients. So you can truly tell them the treatment that we chose for you is working perfectly for you. So we see each other in 2 months, 3 months, 4 months. I think that's very, very important for these patients. So although we see them in the longer intervals, we have, I guess, less chance of losing them over the time course. And as Ian pointed out before, when we say we have 5 or 6 injections less, well, imagine 5 injections. That's basically 1 year of treatment, right? So it's not just 5 injections. For us, it's 5 times putting a drug into the eye. But for a patient, when you kind of add that up, that's a year or even longer coming to the clinic. So I think that's very important to note here.
Ian, how do we do with the previously treated patients, for example? If you have a patient like this one, that it's a diabetic patient with a DME that is clinically significant on the right eye, so the vision is 20/40. We do start the treatment. The left eye have exudates, but the visual acuity keeps very well, so we decide not to treat. But on the right, we have a partial response, not perfect. In this kind of patient, what do you do? Do you decide to switch or not? Or in those patients where you have a nice response like this one, but the extension is not as you would like to? For example, in this particular case, is 6 weeks, the maximum we got.
Yeah, so there's two scenarios there. You've got the first one where there's a suboptimal response, but if that suboptimal response is still improving, then I would still continue. So let's say I give 3 injections in that individual patient with a diabetic macular edema, and there's some improvement, but it's not got completely dry. Well, as long as there's a delta improvement, as long as there's some improvement that I can go, yes, that's acceptable, then I will continue giving that patient 4 weekly. We've seen that in many of the DME studies, both in the 2 milligram era, but now in the second generation era that we're in now, where it's often for some patients, a slow, gradual improvement in their edema and their vision over a 6-month period. So I think if this was relatively early, then I would continue giving them a 4 weekly faricimab or 8 milligram aflibercept. However, if we're now beyond that period and there's no other change I'm giving an injection, there's no improvement, then I think that would be time to switch. And I think the decision at that point is, when I do switch, is do I carry on at the previous interval or do I reload the patient? And I don't know we have an answer for that at the moment. There are studies trying to identify what we would do. But I think as long as there's some threshold of improvement, I would carry on loading. Once we've reached that there's no improvement, I think it's time to switch. And I think in my own, feeling at the moment, we had a bit more experience with faricimab. So many of our patients start on treatment naive as faricimab, and we will continue to treat them. If they're not improving, we will switch to 8 milligram aflibercept as an alternative. And if there's no further improvement, then we will consider an intraocular steroid.
And if the patient is with one of the first generation, for example, aflibercept 2 milligrams? Do you decide earlier to switch?
Yeah, I mean, I think now that I'm confident that the majority of our patients are on 12 weeks or more with the second generation drugs, I think if you are 8 or 10 weeks with 2 milligram, that's not good enough in my bit. Now, there are some patients who will need that and will not benefit when you switch them, but I'd like to give them the opportunity. So I think if you can't get beyond 8 weeks, then I think you should be considering switching for a second generation drug if you're already on 2 milligram.
Yeah. Andreas, your opinion about that?
Yeah, so we actually just published a study where we retrospectively looked at the patients that we switched from aflibercept 2 milligram to faricimab, and then we split them into two groups. One group that responded to aflibercept 2 milligram and the other group that did not respond to 2 milligram. And what we basically found was that we could extend the interval, and we could extend the interval much more in the eyes that responded previously also to aflibercept 2 milligram, which might not be too surprising, but we could extend the interval. So again, this is something to consider here. So for instance, if you're not happy with your interval that you're currently on aflibercept 2 milligram or any other first generation drug, switching to a new generation drug might get you beyond this previous interval. So I think it's worthwhile considering a switch, even in the eyes that did not so well, or that even did well in previous generation drugs.
Thank you. And your final comments or thoughts, Andreas, and then Ian?
So we have with faricimab and aflibercept 8 milligram, two potent drugs in our hands, two potent drugs that showed excellent functional and morphological response in the phase 3 trials, but even more so in the real world studies. And I think that's reassuring. That's reassuring that we do have now drugs available that we can extend in terms of treatment intervals. And again, that's an unmet need for us clinicians, but it's also an unmet need for the patients. I think we are happy now to have drugs that actually replicate what has been seen in phase 3 trials in our hands in the daily clinical routine.
Yeah, I agree totally, Andreas. I mean, I think 2 milligram aflibercept has been the gold standard for DME for nearly a decade now, since it was first licensed. But I think now we are in a new generation. The second generation drugs with faricimab and the 8 milligram aflibercept have changed the needle. And I think that's what patients, that's what they're expecting. And I think it's what we should expect and demand for our patients, because there's clear evidence from the pivotal studies, a significant real world data. But I think what we've seen on this session is that also from personal experience, we're seeing this on a day-to-day basis for our individual patients with diabetic macular edema. And I think now we're in a different era, and second generation drugs are what patients demand and what we should be offering.
I agree that the most important is that the results from the trials, real world, and our experience are consistent. So this is good for us and this is good for the patients. Thank you, Andreas. Thank you, Ian, for this amazing discussion about this new generation of anti-VEGF. And thank you, the audience, for participating in this activity. Remember to please continue on and answer the questions that follow this discussion and complete the evaluation.
This program was presented by Medscape Education Global.